Let's talk a little bit about cardiac output and how end-tidal CO2 can help us out. And let's just say that your PaCO2, which is the CO2 that's dissolved in your blood, is 40. Your PaCO2 will always be higher than your end-tidal CO2. Normally, there should be a gap of 3 to 5 millimeters of mercury. That's just normal with diffusion of CO2 and scatter of air and all that stuff. But as this gap increases, you should suspect more and more pathology. Anyway, back to the example. If we have a PaCO2 of 40 with a normal cardiac output, we would expect the CO2 that's ventilated here to be, let's say, 38. If this person develops a blood clot, these alveolar units, yes, those are alveolar units, will not be perfused as well. And what we would expect is we would see a drop in the ventilated end-tidal CO2 because the CO2 that's in the blood can't ventilate out when we have our acute PE. Let's say, for example, we have a person who's in cardiogenic shock. So this person would have a PaCO2 of 40 because they're not able to push the blood effectively to these alveolar units. We would see a drop in our end-tidal CO2. I'm just exaggerating here, but maybe somewhere around 20. Let's say you gave them an inotrope such as dobutamine. By increasing the contractility of that heart and increasing our cardiac output, we're going to be pushing more blood to those alveolar units, and we would expect an increase in our end-tidal CO2. At the bedside, you can look to see whether or not your patient is having an effect with the therapies that you're starting. Another way you can use this is to determine a fluid bolus. This has been looked at in small studies, and it has been shown that an increase of 5% of your end-tidal CO2 in response to a fluid bolus or a passive leg raise is consistent with a positive fluid response.